This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Now, how to deal with an unexpected situation where there is a intraoperative miosis and then you realize that the patient is on tamsulosin. Well, this is the video for such a scenario. He's a 76-year-old gentleman who is taking a lot of medicines for hypertension, for diabetes, for heart disease, and he has got a mature white cataract with an underlying brunescent nucleus. On the face of it, it doesn't look to be a very difficult case. It looks to be a routine one. Post the surgery and the two side ports are made, capsule is stained, and the chamber is filled with OVD. At this stage, look at the size of the pupil. Pupil seems to be very well dilated, doesn't look to be having any issue at all. And let's begin with the rhexis. The capsule is punctured with the forceps, the flap is raised, and as I am rotating the flap, the iris starts to come out. Well, that was unusual. I went ahead and replenished and placed a dollop of dispersive OVD on top of the iris so that it behaves well. Eventually, I could complete the rhexis, but the iris is behaving in a very funny manner. It seems to be unusually elastic, and the moment I attempt some form of hydrodissection, the iris starts to pour out of the main incision. Well, at this point, I just stopped the surgery, and this was very unusual. I asked the patient, is he taking any medicines for other diseases, specifically any urinary problem? And then he said, yes, I'm taking. But he didn't feel it necessary to disclose when we asked in the preoperative counseling part. He told every other drug history except this. So this is a classical case of IFS secondary to the tamsulosin which is taking for his prostate problem. So now we have a pupil which has gone down, the rhexis is done, and then we have got a dense nucleus to deal with. Now what should be the strategy? One way is always to continue the surgery with as it is and take other adequate precautions, but my preference and recommendation would be to use a pupil expansion device, which could be a pupil-based device like the Bhex Ring or an iris expanding device like the iris hooks. Well, my preference is to go with the Bhex Ring simply because I don't have to make those additional 4 or 5 ports. And additionally, I think Bhex would provide us reasonable stability to the iris as well, and it might minimize the propensity of the iris to prolapse, although it can still prolapse. And I'll be discussing what strategies to use to minimize this. So basically, Bhex is going to be used as a retainer rather than a dilator. That's what is the purpose to be used in this particular case. I'm going to use a Bhex 2.0 ring here, and the ring is placed inside and notches are being engaged. One peculiar issue which we have is when the pupil dilates well enough. Now in this case it is dilated well because I've used adrenaline inside. When the pupil dilates more than 6 mm, again it can become a little bit difficult to get these notches engaged because 5 mm or less than that would be the ideal one where we can engage this device very easily. When it is very well dilated, hooking these notches itself can become a little bit of a challenge. Now, while introducing the Bhex device or any other expansion device after the rhexis has been done, one care has to be taken that the iris hooks or the pupil expansion device don't engage the rhexis margin. So while introducing that, we have to be mindful that the notches are not engaging the underlying rhexis margin. Inadvertent pulling or stretching, if the notches are engaging the anterocapsular margin, there's always a risk of inducing a rhexis tear, and that could be disastrous. So please be mindful of that. One tip would be to float up the iris just a bit by injecting some amount of OVD under the iris. All the notches are in place now, and now is the time to start the surgery. So now to the next step of nucleus management. So what should be the nucleus division process? In such classical brown cataracts, my preferred technique would be the 4-quadrant technique. But because I'm dealing with an IFIS situation, I would not prefer the 4-quadrant technique. Following are the reasons. See, one of the basic principles to be followed when you're dealing with an eye with IFIS is that the fluid flow or the sleeve of the phaco tip should always be above the level of the iris. The moment it goes posterior to the level of the iris, the fluid coming out from the sleeve itself can below the iris out, and the iris would start pouring into the side port and the main incisions. So the rule of the thumb is that the irrigation plane has to be above the plane of the iris. So if I do a 4-quadrant technique, and because I'll be doing a deep trench, there is more likelihood that the fluid is going to be below the level of the iris, and the chances of iris prolapse would increase. So that's the reason in this case I'm doing 2 or 3 strokes of sculpting, reach 50%, and then shifting to the direct chop technique. So the half thickness small trench is created. The parameters are shifted to the chop mode, wherein the power is 30% longitudinal in burst mode, vacuum is 700 and the flow rate is 30, the tip is engaged and the chop is initiated. The nucleus is then rotated and the vertical chop maneuvers are now being continued. Now because the sleeve is slightly above the level of the iris, there is a lesser risk of the iris prolapsing out. Now this situation is very peculiar to IFIS. That's the reason why we're trying to use this technique. As the nucleus is denser, we need to have multiple levels of chopping. We don't expect the nuclear fragments to divide very easily. A little bit of patience and care is taken to ensure that all the fragments are divided. And we've got about 7 smaller fragments, and then it's time to emulsify each of them one by one. So these are the quadrant removal settings. The power is 60% continuous torsional, a flow rate is 60 and the vacuum is 700. Slowly but steadily each of these fragments is pulled out of the bag and then emulsified in a controlled manner. The left hand instrument is kept above the level of the tip so that it acts like a shield and prevents the fragments from running away and hitting the endothelium. It's mandatory that we replenish OVD a couple of times as the nuclear fragments are getting emulsified, simply because each of these fragments can just jump out and hit the endothelium. Now, these hard fragments can cause mechanical damage to the endothelium if they slip out and fly and hit the back surface of the cornea. The power delivery is titrated very carefully by the control of foot pedal so that we don't have any lens chatter. So the final fragment is then aspirated, the cortex is removed, the lens is placed in the bag. Time to remove the Bhex device. And once the Bhex device is out, again we can see that the propensity of the iris to come out, the OVD both in front and behind the lens is aspirated out. The side ports and the main incision are gently hydrated, and that's it, the case is done. So this pupil is a classical example of an elastic pupil. It's not a rigid pupil, because look at the way and the ease with which it dilates and retains in the position. If it's a rigid pupil, you can't dilate it. The second indication is whenever the OVD was put, the iris would change its shape. This is possible only when the iris is very elastic and floppy. So lessons to learn from this case. In the event of an intraoperative miosis, like in this case where the patient being on tamsulosin was revealed only at the table and you have gotten dense cataract underlying, there should not be any confusion. Like, apart from using the pharmacological agents, like I added intracranial adrenaline in the BSS bottle, but apart from that, having a pupil expansion device does help. It is not to dilate the pupil, but basically to retain it in that position and minimize the chances of iris prolapse. Mind you, even with these devices, there is a risk of iris prolapse happening, but if you're careful with the fluidics and the plane of emulsification, one would do well. So apart from using the pupil expansion device, other measures like, trying to use a nucleus division technique wherein the sleeve, which has the holes for the fluid, does not go below the iris would be beneficial, would minimize the chances of the fluid getting under the iris and inducing iris prolapse. And this is one rare instance where I would recommend a more anterior plane of emulsification, because if we go more posteriorly, the incidence of the iris getting billowed and the iris starting to prolapse would increase. So 3 things. 1, use the Bhex device, prefer a direct chop maneuver, and 3rd, have an anterior plane of emulsification. So that was it. Thank you for watching and hope you found this helpful.